Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
So psychiatry in and of itself, my goal here is to do a few things, to be able to describe some of the work that's inherent in psychiatric practice. In medical school and beyond, there is a model that you learn on rotations called the biopsychosocial model. And I think it's really helpful here, and I'll try to scaffold it in a way so that even pre-meds can understand why it's useful to think about your cases and just in general life from some of these aspects. There's 4 Ps, which have become very clearer later on about this biopsychosocial model. We'll go through some cases, and I'll talk a little bit about that when we get there, and then why the necessity is in psychiatry, as we were talking about having multiple modalities, multiple dimensions in treatment. Oops. So psychiatry, broadly speaking, I actually tried not to look up a classic definition here and think about what the way I would see it. It's more or less the way I see it is that the study and treatment of behavioral manifestations of disease. We often think of this related to the brain, right? And that's why you have this brain on the side. So why psychiatry? I think there's a real neat aspect here of you being able to help people to empower themselves to solve their problems. You think critically about aspects of your patients' lives, and you draw up multiple disciplinary solutions in concert with others. It's very intellectually rewarding and personally as well. There is a sense that there are very few clear answers for problems, and for some people that can be really frustrating. For other people that it is really exciting. And there's a lot of overlap. Like I found when I did rheumatology rotations, actually, that there was a lot of overlap there too, and that psychiatrists and rheumatologists often got along for that because they're just not very clear answers to rheumatologic problems. You learn a great deal about yourself through the training process, which I think it can be true of any residency, but I think is like part and parcel of psychiatry. If you're doing it well, you should be getting more insight into yourself. And then therefore the skills you learn in life are really invaluable because you can apply them in multiple ways in your own personal life as well. A couple of things that I think are really, now I've realized is that, there is some ageism in our society, and if you do procedure-based specialties, you have to be able to continue to do them, right? Whereas as you age in psychiatry, the breadth of knowledge you develop actually makes you more esteemed, even if your physical skills start to deteriorate a bit. And the practice is very flexible. So it's still possible in psychiatry to be your own boss, whereas in many other specialties, it's really very challenging to just hang out your own shingle and do it yourself. And there are many psychiatrists who do some combination of their own clinic and then working part-time in other settings as well. And I think that brings some job satisfaction related to that. So a day in my life, a lot of it has to do with what my personal life is. I get woken up with my kids really early. I help my family prepare for the day. I'm really happy now. One of the things I get to do is walk to work, right? And it is really important to me to think a little bit about how our work intersects with things like climate change. And that's something I think is really, can work with mental health as well. I get to work and we discuss the learning objectives and to-dos with staff and students. We get the morning report. We intake new patients and round on remaining patients. And the real core of it is these treatments, which I'll get into a little bit more. A couple of days a week, because I'm still in training. One of the days I have an outpatient clinic, and the other one I have didactics in the afternoon. And the afternoon is really, after I go home, is really meant to be more of like my personal experiences, exercising, doing some, like started a garden during the pandemic and really like it. And then spending time with my kids. The cases are complex. So, what I tried to do is some composite of things of things I've seen here, because the nature of psychiatry and the intimate work we do, if I try to individualize anything, it doesn't work out very well for that person. So if we take this example, which I think I'll try to walk through, an adolescent presenting with suicidal ideation. So what's going on with that person? The patient has been more reclusive and withdrawn since the COVID-related lockdowns and the George Floyd-related racial unrest. And the person explodes with anger towards parents, stating that the parents invalidate their opinions, is now failing school despite being a high-achieving student previously, and it's mostly online school now too. And they wound up telling a friend that they were thinking of killing themselves, and the friend notified police. No previous interaction with the healthcare system beyond routine well checks with the pediatrician. And on exam, which I've seen, frequently the patient can kind of will selectively answer questions and otherwise remain silent or sobs profusely. And the first thing I do in this setting, right, if I'm, this is a kind of a case I would see maybe perhaps in the ER, is my job is to decide what is the least restrictive treatment that can be applied to this person. Does that mean inpatient hospitalization? Where, the nature of an inpatient psychiatry ward is that it's a locked unit. You have restricted access to the outside world. And so there are some real downsides to someone coming in. And that's why we think of what's the most beneficial way to treat this person, which may not be necessarily in the hospital setting. But there are times when we determine it makes sense for the person to be in the hospital because they may be a danger themselves very quickly, but the patient may not want it. And that's also a challenge too. And that's a really kind of fascinating part about psychiatry that we work through. I won't get into much detail about this, but it is kind of a unique aspect of, well, maybe not unique, but an interesting part of what we do. Well, what if an inpatient hospitalization is what we don't need, but an outpatient clinic treatment makes sense, or somewhere in between? And there's this kind of structure in psychiatry of, okay, well, the inpatient hospitalization, and then maybe you have places where you go during the day, but then you go home at night, or you're just having your kind of, clinic appointment that you have every so often. I think we talk about this biopsychosocial model, that it's helpful to diagnose, sorry, let me move this a little bit, diagnose how we treat people. And what we think of is really the continuum of how a person interacts with their society. So, we can affect change as physicians at an atomic level, subatomic level, with medicines, with interventions, with procedures. But, people don't live by themselves. They live in an ecosystem, and that ecosystem also affects them. Maybe the family, the culture, the society, and the nation. And in order to really effectively treat someone, you ought to be thinking about how all these experiences kind of combine together. So the biological basis of psychiatric disease is something that we in psychiatry obviously think about a lot. You could think of these 4 Ps, that they're predisposing elements, right? There may be hereditary components. I think there's kind of interesting work in behavioral genetics, which I was recently reading some work from Robert Plomin, who describing maybe 50% of what we think about of inherited of characteristics that we think about in disease states, including in mental health disease states, or ones we can attribute to genetics in some way, right? Or the variance that we see is from genetics. And then, everything other than that may be environmental, but it may not be really easy to find out what the environmental characteristics are involved with that. It's also important to know something about the neurodevelopmental history. Are there insults from earlier on that may have made it more difficult for the person to cope with certain situations? And we'll get into that in a little bit. There could be precipitating events that happened in the more acute setting, drug use or sleep deprivation, and then things that make it very difficult for that person to cope in that moment. Maybe either being treated or a lack of treatment within the mental health care system. There's certainly more, but this is one of the things I gave. And then things that protect this person, the patient's health, and that they're that or the family, right? So it's ecosystem that can kind of protect them. I'll kind of do a formulation of this case in a little bit, but first I want to talk a little bit about Something that I found really interesting in neuroanatomy, specifically the ventromedial prefrontal cortex, which is really rapidly developing in adolescence and modulates the processing of risk and fear. And there's this, famous case of Phineas Gage, but also within adolescence too. But Phineas Gage was a guy who in the 1800s had some rebar or something like that actually go through his ventromedial prefrontal cortex. He preserved his intellect, but he started developing all these really clear antisocial behaviors, so things that were just not productive in society. And adolescent anxiety disorders have been associated with abnormally increased activity here. So there is a biological correlate why someone might be coming in a suicidal state, right? Because their processing of risk and fear may just be different. And that might be developmentally appropriate, but also that the disease state might be affecting it too. There are sociological components we should be thinking about as well. So adverse childhood experiences, which is something you learn in your pediatrics rotations, traumatic experiences that can affect you in childhood, but throughout the course of your life as well, can lead to have been associated with disease development. Identity conflicts, which we'll get into in this case. Recent traumas, chronically unstable environments, and then protective relationships that can help. It'll make more sense when I talk about this case in a minute. And then the psychological aspects. It can be difficult, and these things all kind of overlap to understand, well, where does one fall and the other one doesn't? But in this case, we're talking about the family structure, the attachment style, which is something interesting. When you think of someone who grows up and we think of an intact or a stable household, the ideal there is that the child knows that their parents will love them, sort of regardless of the situation, and they can feel secure in that relationship they have with the parent. But if you grow up in a household with adverse childhood experiences, divorces, deaths, and so forth, you may not necessarily have that secure attachment. And that maps on to other aspects, other relationships you have in life, where you may not necessarily feel that your friend or your colleagues or something like that are someone you can trust. And that has a lot to do with what we think about this kind of attachment style. Precipitating factors, like how do you cope with stressors and things that people use in their childhood in order to cope through the challenges kind of become more difficult in adulthood. You may develop cognitive distortions. You may emotionally dysregulate. So for instance, if you grow up in a household where it's very difficult to get attention, and you realize that by causing a big scene, you get attention, that may work as a child, but then obviously when you get into the workforce, it's not going to work very well. And then unconscious conflicts. So things that you're not necessarily on your mind, but are kind of come out anyway. And then we'll get into a little bit about how reflecting, having better insight actually makes you a better person, being able to cope with these things. The last part, I think, with identity, I think is really important because this is kind of the bedrock of what teenagers go through. That there is some sense in being different, right? That's kind of a lot of what teenager experience is that you have some disaffection within your family, and then more broadly between how you fit into the world. You're trying to figure that out, in part because you're not a child, you're not an adult. So it's a natural time where you start to question that. And then when you add in, kind of social unrest, that makes it much more challenging. You may feel isolated or different and feel as like a pariah or a black sheep as a result. And then as we talked about, there's some degree of impulsivity that's actually developmentally appropriate at that point. But it can lead to challenges then when you don't have the kind of ability to reflect upon, well, is what I'm thinking about true? Or is it just my perception of that? And that's where these cognitive distortions come in. And then you start to feel more and more different as a result of that. And then naturally, as a teenager too, we're talking about a lack of autonomy you have because you just simply you don't have the same agency as you do as an adult. But on the other hand, you find that teenagers find identity in similarity. So they find social groups, social networks, specific groups of people that share some of those same values. And they find that in that community, there's conformity there, right? So then they start closing in that if you share some of those values, then it's important to share all of them together because you want to be exclusive and authentic, in part because you're disaffected from the society at large. And there is this kind of drive that we all have to be accepted. So where does that leave you in the middle, right? This is a Venn diagram where you kind of overlap. And if you're pulled between these two sides, you can naturally imagine that you have an identity conflict and all sorts of chaotic emotions that are just all over the place, right? And in this situation, when we think about this patient, that may be some of what's going on here. So in this patient, we have someone who's maybe biologically predisposed to a family history due to, and I didn't describe this earlier, I meant to, but they have a family history of anxiety and alcohol use disorder. And they have some executive decision making that makes their impulsive decision making like kind of worse, right? That's just developmentally appropriate. But then maybe because of the history of anxiety disorder in the family, that their fear responses are worse than typical. Then you may think about the psychological experiences of invalidation, right? So we have these experiences where they're trying to, maybe the parents and the kid aren't connecting, and the kid's exploding with anger, or you just don't understand me. And because they have an anxious background, right? Their temperament is anxious because their parents are anxious, that they may have a core belief that they're being abandoned. So when you're having a conflict with your parents, it's not just a conflict and you get over it and you move on. It's like, my parents don't understand me. They don't get me. They're not even part of me, right? I'm different from them. I'm isolated from them. And that allows you to think more rigidly in your thinking. For instance, these feelings will never go away. They will never change in time, even in adulthood. I'm always going to feel abandoned. And then you have social isolation due to COVID and alienation stemming from, the George Floyd experiences. So it may be that if you don't feel like you fit in society, right, and then you're not able to talk to other people, or you find community in a small group of people who are also saying, I don't fit in and forget it's not worth it, then you stop being able to see different perspectives. And then you start having more and more concerns that you don't have a place in society. So this may lead to a belief that the only way to end the stress is to end one's life, because it's never going to get better. So treatment, well, medications are what we think about, right, in allopathic medicine, and they can affect all three of these biological, sociological, and psychological domains, right? If you are less anxious at baseline, then you can improve your ability to see different perspectives and have a different psychological makeup. And then obviously that affects your biology as well. But it's not the end all and be all of treatment, because you really need complex planning and execution, as Dan was just asking about. We can affect the atomic level, but in order to really do good for the person, we ought to be thinking about how they fit into their culture, how they fit into their family, and how they make sense of that. And we help them to help make sense of that. And so treatment ought to include their parents as well. And so this gets some of what you were asking about, Sam, as well. This is a very complex problem. How do you tease some of this out? And it's not that I'm just talking to the teenager. I'm also talking to the parents. In fact, there are some times where the teenager just doesn't say anything at all. So this is where it would have come out earlier, and I forgot to have mixed around the slides, but the parents found out about the suicidal ideation from the police who came to the house to check on the patient. So the parents were essentially clueless up until this point. They knew something was going on, but they didn't know that the kid was actually suicidal. One parent grew up in a household influenced by alcohol use disorder. So then you have an idea that the parent, him or herself, really has a concept of what alcoholism can do in a family. And both of the parents are high achieving professionals who had an emphasis on educational achievement. So we have an idea there that maybe that this was a source of validation within the family of getting good grades. And then all of a sudden when they fall off the map, you don't feel necessarily the sense of connection anymore. The parents themselves have had intermittent treatment with therapists for anxiety. So we have some background of anxiety within the parents themselves. But due to COVID-related visitor restrictions, which is true, only one present is available for the exam. The other one has to either call in or is not available. And this person's kind of shocked and upset and tearful. And so in this experience, this helps to put together this biopsychosocial model. And you ought to be thinking about how the treatment goes for parents too. And this I think, is one of the exciting but challenging pieces of child psychiatry in particular, is that you are thinking about sort of an ecosystem. And pediatrics and a few other specialties really think of this as well. We want to at least make some effort to formulate the family's conceptualization of the world, and then also the family's conceptualization of the patient, right? So how did the parents think of the patient, him or herself? And it may not be as detailed as this, right? Because frankly, the biopsychosocial model is a nice theoretical framework, but on a day-to-day basis, it's very long and lengthy, and it's very difficult to do. So you're thinking about bits and pieces of it. But you also want to think about how the family's experience affects the patient's perception of this. So it's both how the family thinks of the patient, but then because of how they treat the patient, how does the patient then think of the family role? So if you have someone who, like a family, for instance, in this sense, is sort of anxious, puts a lot of emphasis on education, the kid starts falling off the rails because they're feeling isolated, they don't understand their place. Well, that makes it all the more difficult for the family to piece things together, right? They're already not connecting. And so then one of the neat parts is, what is a psychiatrist's role in family treatment? We're kind of some of the quarterbacks in this. And so we are putting the pieces together of the psychologists, the social work team, and the interventions we do as well. There is this talk, or there's kind of an adage in psychiatry that, all we do is talk. We don't actually do much of anything there. And I think that there's this important piece that I think that's, fairly accurate, but something that's worth thinking about, because talking actually does do a lot. So I just threw in a study here of a meta-analysis of 33 articles investigating just the neural mechanisms and responses to psychotherapy, meaning talk therapy. And it doesn't include the type of talk therapy, which is not worth getting into in this talk, but they kind of attempted to address what's thought to be two things, which is increasing the emotional regulation in the prefrontal areas, which we talked about a little earlier, is involved with your ability to kind of mediate fear, but also how you think about the world and how you be able to think critically and stop yourself from making an impulsive action. But then also to down-regulate your emotional reactivity in the limbic area, like in the amygdala, where you have an intense emotional response to something maybe disproportionate. It's not that big of a deal, but you overreact to it. And then the big finding from this was that there was a significant decrease essentially in the limbic system response here, just from the experiences of talk therapy. So talk in and of itself actually is, as we kind of anecdotally know, is really important in healing and is actually a therapeutic treatment. So it is important no matter what area of medicine you go into, I think. I want to keep that in mind. Although interventional psychiatry exists, there are ways you can do transcranial magnetic stimulation to treat depression. Ketamine is a new big thing. Psychiatrists are obviously heavily involved with that for treatment of depression. There was a FDA approval for a ketamine-based treatment. And then ECT, which was kind of most well known for One Flew Over the Cuckoo's Nest, but has been an effective treatment for depression for many decades. So there are ways you can do procedure-based psychiatry. But I think the way I conceptualize psychiatry has far more to do with that you're the quarterback of a team that's really making these multimodal interventions. Oops. And the last thing is, so just to review, so some of the work inherent in psychiatric practice, we do a lot of conceptualization of how people fit in the world. We help them try to understand themselves and develop insights into that, which is a protective force, one of those 4 Ps, right? So then they can kind of change their behaviors once you develop an understanding of, well, this process that I'm using to react to a situation is not always helpful. And then I can go about changing it. But then there are other ways to do the work. You can work in an ER setting, you can work in an inpatient setting, you work in an outpatient setting, do some of the same things. You can do interventional-based psychiatry. This biopsychosocial model we use to conceptualize disease, and this isn't just true in psychiatry. I think it makes sense in many other fields as well, and help you understand a little bit more about why your patients come there in the first place. And then how these 4 Ps, which we described a little bit earlier, help understand a little bit about how you treat people. And then we apply this to the cases. And I think that is what I have.